Good afternoon and welcome, everyone. We'll be starting the webinar in about a minute. We're just going to wait and see if anyone else is joining. So we'll start in just about a minute. Okay. Welcome to today's webinar, Report Back from SGO, What's the Latest in Uterine Cancer? My name is Kitty Silverman. I'm the Uterine Cancer Program Director at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast, ovarian, uterine, and metastatic breast cancer for the last 45 years by offering the support of those who have been there. SHARE provides many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. For more information, please visit our website at sharecancersupport.org. All participants will be muted during the presentation. When Dr. Villella finishes presenting, we will begin the Q&A session. You are welcome to submit questions during the presentation through the Q&A section at the bottom of your screen. The chat section will be disabled. When asking questions, please remember that the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. Now I'd like to introduce our speaker for today. Dr. Jeannine Villella is the Chief of Gynecologic Oncology at Lenox Hill Hospital, Northwell Health, and Associate Professor at Zucker School of Medicine at Hofstra, Northwell Health. Dr. Villella completed her obstetrics and gynecology residency at Winthrop University Hospital, which was followed by a 2-year postdoctoral clinical fellowship in advanced pelvic surgery and research at Columbia University College of Physicians and Surgeons. She also completed a 3-year subspecialty fellowship at Roswell Park Cancer Institute in gynecologic oncology. Dr. Villella is board certified in both gynecologic oncology and obstetrics gynecology. Please welcome me, and please join me in welcoming Dr. Jeannine Villella.
Hello, how is everybody? Thank you for joining us today. Thank you, Kitty, and the program committee. I really appreciate this opportunity to be with you today. And actually, I was really excited because this year was Uterine Cancer's year for GYN, for SGO. So it was actually very exciting. So I'm happy that I could be the one to come and talk to you about this today, because it was a very good year for uterine cancer at SGO. A lot of excitement. So I'm just going to, okay, so I'm going to give you some background first. We're going to talk about, statistics and sort of how cancer sort of develops. And then we're going to go into sort of what's happening and what was discussed at SGO, and maybe some that wasn't only SGO this year, maybe a little bit from SGO last year that led to some publications this year. And just really, it's just going to be a conversation. A lot of the slides are very clinical and scientific. And so I'm going to try to go through them, really speaking over them. So it's more important, I think, to just not get overwhelmed by the slides and just listen to what I have to say. And I'm really looking forward to fielding questions. So, uterine cancer is the most common cancer that I see as a GYN oncologist. It affects 65,000 cases a year. And, by and large, most patients have early stage disease and they do very well. But there are a significant portion of patients that die of this disease. And it's actually the 6th leading cause of cancer death for women in the United States. And unfortunately, it's one of the few cancers for which there's a rising incidence, which means that the number of cases are going up and the survival's going down. And that's really concerning. And so it's notable now, especially that there's a disparity of healthcare outcomes. Like Black women are diagnosed with more advanced disease. They tend to have more aggressive tumor types, and they have a worse 5-year survival. So this is really an unmet need because of those reasons. So what is cancer? Well, everybody's cells in their body, normally divide. And they do that for really a long time in your life. And normally you have checkpoints in your body or ways your body cleans up mistakes that it might make. And it causes those cells to die. So what happens in cancer is actually some kind of mutation occurs in the cell, and it actually doesn't die. It keeps promoting those abnormal cells, and they lose, it's kind of, they lose control. And so they don't know normal boundaries. Like, it's like they don't know how to behave. And so they start invading other areas, they start invading other organs, and they spread, and they continue to do that. And that's how cancer starts. It's hallmarked by uncontrolled growth. And then what can happen is it starts to spread, and it spreads by like a piece of the cells breaking off, and they go through circulation, and they colonize in other areas, and that's how you develop metastatic disease. So that's really how cancer starts. And well, how does this DNA abnormality, or how does this abnormalities happen in these cells? And usually we know that there are genetic mutations. So we do know that cancer is a genetic disease. Now, it doesn't mean that it's hereditary, but it's genetic because the problem is with the cellular DNA, or the genes in the cell that allow these cells to become, malignant and cause problem. So there's things that you can have. We know tobacco, diet, obesity, physical inactivity, alcohol use. These are things that we can modify, right? These are modifiable factors that I know. If I don't smoke, I keep my weight under the normal range. I try to exercise, don't use too much alcohol, keep a healthy diet. These things are what we can do to sort of prevent the extra mutations. But that's not all. Cancer is multifactorial. So there's other modifiable factors, infectious agents, occupational exposure, environmental pollution, radiation that's just in the world, and UV radiation from the sun. These are secondarily modifiable. We can decrease our exposure to these agents, but we can't really mitigate them or wipe them out completely. And then there's non-modifiable things like aging, hereditary, things that you inherit, genetic abnormalities that you inherit from your family, your gender, your ethnicity, and your race. These are things that we cannot change. So we try to do what we can to modify the primary modifiable risk factors, and then try to decrease the secondary modifiable factors. But by and large, there's some things we're all going to age, unfortunately, and this is what can happen and cause cancer. So one of the things we know is obesity can definitely cause cancer, and it's a known association, especially in breast cancer, colon, endometrial cancer. And we know that obesity is on the rise in this country, and it's one of the modifiable risk factors that we can do to decrease cancer. But we know, so from 1992, you can see in red, the number of cases that have gone up of over 55% of the state is obese is really increasing, and it has dramatically. And so, this is of concern when it comes to endometrial cancer. And we know that, why is obesity bad? Well, research suggests that that in fat, it's, when they say like this abdominal fat is bad, well, because it actually is like metabolically active, and it actually changes, it changes cells and has them secreting factors that can increase the risk of inflammation. And when things trigger inflammation, that can actually increase your risk of cancer. And we also know that in fat cells, we have increased estrogen production because we aromatize testosterone in fat cells. We aromatize other hormones into estrogen-like products that increase risk for endometrial, ovary, breast cancers, and even colon cancers. So we know that actually if patients lose weight, it could decrease the incidence of cancer. And even patients, there was some large studies that if they have they lose weight either by gastric bypass or by diet, that actually the risk of cancer is lower, and actually the outcome from cancer, if you have it, is better. So another thing that can happen for endometrial cancer is Lynch syndrome. This is kind of rare. It's only about 3 to 5% of uterine cancers, and the prevalence is really low in the population, like 1 out of 600 or 3,000 women. But this is hallmarked by multiple cancers in young women. And over 50% of cases, endometrial cancer is the most common presenting cancer in 60% of cases. So those patients have an endometrial cancer risk of 60%. They have a colon cancer risk of almost 80%. They have about a 6 to 10% chance of ovarian cancer risk. So these patients, you know, obviously we know these are hereditary causes. This is when you pass down the gene from in your family. And because of that, we recommend surveillance for these patients. So for uterine cancer, we recommend that we, you know, do endometrial biopsies every 1 to 2 years, starting very young. So, you know, these are cancers that this is a genetic cause that's autosomal dominant that's passed down from families. So if your mom has Lynch syndrome, you have a 50% chance of inheriting that gene, and men as well. And you know, we know that if you remove the uterus, for uterine cancer, that your risk goes down to 0. So that's a good thing to know, that we at least can, you know, get rid of this risk to 0, because not many cancers can you reduce risk to 0. So where are we now? So since 2003, I would say at that time, there's been a lot of change in endometrial cancer. Up until 2003, laparotomy, which is a big incision on your abdomen, like from your belly button down to your pubic bone, where we did a hysterectomy, and what we did called the lymphadenectomies. We removed lymph nodes in the pelvis and around the aorta, and a lot of patients got adjuvant radiation and or chemotherapy, even for early stage disease. Well, the problem with lymphadenectomy is that you can get lymphedema, which is swelling in the legs. That's chronic. You know, breast cancer patients can get that. So sentinel lymph nodes that was being done for a long time for breast cancer is now being done for endometrial cancer. And the LAP2 protocol showed also that you can do laparoscopy, and you can have similar oncologic outcomes with less complications and improved patient satisfaction and length of stay. And now we're moving to sentinel lymph nodes, where you don't have to remove all the lymph nodes in the pelvis, so it decreases lymphedema, and the oncologic outcomes are similar, less complications, and you improve patient satisfaction. So that was a huge change, right? Because these women, you know, if you think about the fact that your uterus is only about the size of your fist for most people, if you had your incision all the way up to your belly button, at least, that's because we had to get to the para-aortic lymph nodes, which are right underneath your belly button. So those incisions were really for staging purposes, but now we can actually do that with lymph node, with laparoscopy, and we don't have to remove all the lymph nodes, so that in some cases, you can remove only 1 or 2 from either side, and that will, if those are negative, your risk of having any of the lymph nodes in the aortic area is also negative. So, so that has really improved outcome for women and decreased lymphedema, lymphocyst formation. And improve patient outcome and satisfaction, of course. And then there's been Portex studies that actually narrowed down indications for radiation. We used to really, by and large, most people used to get pelvic radiation. At one time, we were doing abdomen radiation. But now we know targeted radiation with, and maybe even just vaginal radiation really is utilized, and it decreases toxicity. Patients really have much better outcomes, so that has really changed since 2003, which has all been really good advances. But unfortunately, when it came to recurrent disease or advanced disease, we really was stuck. You know, we had chemo, which, you know, we all know that if you don't need chemo, it's great, because chemo has its own side effects. And actually, in endometrial cancer, chemotherapy is effective. As you can see here, is anywhere from, you know, 4% to 51% response rates. And actually it worked for several months, and this was good. You know, these were good, good studies, but, you know, we were kind of didn't have a lot of options. You know, this was it, you know. So now there's been a lot of new advances in endometrial cancer therapy, and mainly immunotherapy complications, and we're going to go through some targeted therapies and some hormonal therapies. So this now is really an interesting time. So we know that endometrial cancer treatment is not just one size fits all. Like, you know, you have one cancer and this is, you know, what you're going to get like everybody else. Now, endometrial cancer is really moving into this precision therapy where we look at patient factors, drug factors, tumor factors, and we try to get this optimized interaction so that we can do the best for the patient. So for instance, we now classify uterine cancers. We always, you know, had type 1 and type 2, but now we need to know the histologic type. Is it endometrioid? Is it serous? Is it clear cell? Is it sarcoma? And also, you see down here where it says molecular markers, you know, we used to just do this pink and purple here, as you can see, that's what we call immunohistochemistry and or IHC. And as you can tell, if you look at these three cancers, these four cancers, they're all different and they look different, right? Well, now we know that not only do they look different under the microscope to the pathologist, they actually look different at a molecular level. And so we never really used to pay attention to that. We were like, oh, uterine cancer, endometrial cancer, you treat it with this. Well, now we know, listen, there's a lot of other things that we need to know, including these molecular markers. And that's a lot what we're going to talk about today. So I don't know if you guys saw this, but, you know, immunotherapy, these are just a few of the big breakthroughs that immunotherapy has done. It really has changed how we treat cancer and people's response to cancer. And now, you know, there are a lot of people living with cancer based on a lot of these new outcomes. So, and actually the Nobel Prize was won for cancer immunotherapy in this area. So we know that the immune system can recognize cancer, right? We know that if a cancer mutates, it's abnormal. And your body has these cells that drive around your whole circulating system and pick out the ones that are abnormal. So if it can do that, why can't, you know, it kill cancer? Well, we always knew that it could, but somehow we just didn't know how to make it work for us. You know, we know this is going on in our body. So how does immunotherapy work? Well, this is one of the ways it works. We know that tumor cells bind to immune cells called T cells and inactivate them. So it's kind of like, you know, if you put you know, a bank robber will, you know, inactivate the cops, you know, sort of, so to speak. And so what would happen is that the cancer cells would be able to, you know, run around and spread. However, if you block that interaction, you could allow the immune system to do its job and kill the cancer cells. So sort of that's the sort of simplified version of what immunotherapy does. And all different types of immunotherapy work differently, but just in general, this is what we're going to be talking about today. So one of the other things we know is that tumor cells, cells have a way of repairing themselves. Like all of our bodies, we have tumor suppressor genes. We have certain cells that repair damages that the cells make up all the time. It's kind of like the way they can correct mistakes, and that the cells can, you know, otherwise maybe that would have made a cell turn into a malignant cell. They can actually repair these areas. So we have mismatch repair genes that actually can help repair genes and actually restore them to normal. But if they're mutated, they're not going to work, right? So that's one of the things we're knowing, that patients that with endometrial cancer might have mismatch repair genes that don't work right. So these MMR genes aren't working right, or they have microsatellite unstable tumors, and so basically your body can't correct these normal mutations, so cancers occur. And we know that this drug, I don't know if you've heard of pembrolizumab, it was approved in 2017 for tumors that are MSI high or have this mismatch repair gene deficient, that they don't work properly. And actually, these drugs have actually showed, namely pembrolizumab and dostarlimab, have really shown, you know, response rates that are pretty good, and actually the duration of response, you know, over a year for recurrent disease in MMR deficient patients is really amazing. And we'll talk a little bit more about dostarlimab later. We know that if tumors have mismatch repair genes that are intact, that this doesn't work as well. And so this is what we're realizing. We can't treat everybody the same, like one size fits all. Now we have to know all these little nuances that we never really knew before, and we never even tested for. over in the last few years, we've been doing this. It's called next generation sequencing and testing, and some immunohistochemistry. And this is really changing the way we treat cancer, especially endometrial cancer. So this was a great trial that was done looking at pembrolizumab and lenvatinib. Lenvatinib is a TKI drug. It basically inhibits multiple targets, it works with pembrolizumab synergistically. So they both help each other kill tumors. Because of the way that lenvatinib, I'm sorry, works a lot on this VEGF, it can cause hypertension, it can cause fatigue, diarrhea, and weight loss, which happens with pembrolizumab. So this combination got accelerated approval from the FDA in September of 2019 based on amazing phase 2 study results. So basically, this is for advanced or recurrent endometrial cancers. Give lenvatinib, which is an oral drug. You take it every day, and then pembrolizumab every 3 weeks. And that was, one arm was that 1-to-1, and the other patients got either doxorubicin or paclitaxel, which both are the most active agents at the time, single agents. They did 827 patients, and they found that actually patients did very well on this. The problem was they got a lot of toxicity. So a grade 3 toxicity is a severe one. And in the experimental arm with these immunotherapy and targeted drug, look, 99%, like everybody had like a severe toxicity. So they had to have a lot of dose reductions, like almost 70% of patients literally couldn't tolerate the drug, and they had to bring the dose down. But I just want to show you here, if you look at the progression-free survival and the overall survival, if you see these curves, the further apart they are, this is chemo and this is the study drugs, the lenvatinib and pembrolizumab, you can see that that's really very good. And this is why this combination improves progression-free survival and overall survival as compared to chemotherapy. It's much higher, and that's what we want to see in these trials. This is called the Kaplan-Meier curve. So the farther apart they are, you always want to be on the top one. That's usually the better arm to be in. So what do we know? Well, we know that this is a standard of care for people that have actually MMR genes that are actually working. But we need to keep in mind that in this study, they used a single agent treatment as the comparator arm. We know that if you use carboplatin and Taxol, patients do well. We also know that maybe some hormonal therapies would have been much less toxic for these patients and controlled the disease. And in fact, they had a lot of toxicity. So we have to proactively talk to the patients about the drugs. You have to really watch them for toxicities, and many of them won't be able to stay on trial. So they're actually really studying this, but these results were actually excellent, and we're really, this is very commonly used in the clinic now for patients. So there's other immune checkpoint inhibitors and TKI combinations, which is, the drug like lenvatinib, that are being explored. So now there's other drugs that we're using in combination and looking at these. So hopefully by next SGO, we'll have even more good results and options. So we know that if patients have those mismatch repair genes that aren't functioning, actually those people actually do much better with these immune checkpoint inhibitors like pembrolizumab, dostarlimab, avulimab, and durvalumab. This was approved, for any treatment of tumors that have either very unstable tumors with mismatch, deficient mismatch repair genes, or microsatellite high unstable tumors. So pole mutated tumors, these are tumors that are very, very ultra mutated. They have multiple abnormalities, and they actually are very unstable tumors. And these actually respond well to pembrolizumab. So we weren't really testing routinely for pole, and a lot of people still don't, and because it's you have to send out for several tests. Not everybody does these testing in-house, but just to show that this tumor has shrunk here. You can see this large tumor, and it shrunk down dramatically with just 8 weeks of pembrolizumab, just because this mutated tumor has sensitivity to checkpoint inhibitors. So it doesn't mean it's not enough now to know that you have endometrial cancer. There's a lot more information that we need to get to really give our patients the excellent treatment that they deserve. So another one, dostarlimab, is also an anti-PD-1 therapy associated with for patients with recurrent or advanced deficient MMR tumors and endometrial cancer. These patients were treated with dostarlimab IV every 3 weeks for 4 cycles, and they switched to every 6 weeks. There was 104 patients. The median age of the patient, which was like the average age, was 64 years, and they were followed for 11 months. And actually, they have a really good response rate. It was about 42%, and actually 13% had a complete response. So, but the most important thing is the likelihood of maintaining this response at 6 months was 96%, and 3/4 of the patient at 12 months still had a good response. So that's actually really important, because we want these responses to last, right? So that was good. Then there was a Garnet trial, which also confirmed this. It was advanced patients with progression on platinum treatment. You had deficient tumors, and on patients they had 110 women with mismatch repair deficient tumors, which means their tubals were unstable. They weren't able to repair themselves. They had a 46% response rate and a disease control rate of 63%. So that's 2/3 of patients. If you have a proficient tumor, which this is the one that, they can repair their own genes, but somehow they don't, and they have a very poor prognosis with limited treatment options, because, they don't respond to immunotherapy. And they had a follow-up, but they found at 13.7 months, they found that about 15% of patients had a response, and they controlled that rate again, 63%. So this is this subgroup of patients is really important, because these are the ones that a lot of times we don't have options for these patients. So again, knowing your mismatch repair status, knowing your MSI status is very important. And what's interesting is uterine serous tumors, which we know have been a very aggressive type of tumor. They tend to spread, even early stage recur. 19% of these patients, of this subgroup of patients, had mismatch repair proficient tumors, and actually would be responsive to dostarlimab. So this was really good news. I think this was one of the a really interesting paper. And interesting, this also included carcinosarcoma, which in the past we really had no options for treating these patients. So this was a good news in this area. So let's talk about hormonal therapy. We always knew that, many, especially endometrioid types, can be hormonally positive, ER/PR, estrogen receptor, or progesterone receptor positive. And the response rates were good, but, it didn't last too long. The progression-free survival is about 3 months, even if the response rate was good. Remember, so this is what we really want to push out. We want to push out this progression-free survival. And in fact, now we know targeting HER2 and endometrial cancer, which we've heard about it, targeting it for breast. We know that if you target these areas, that are mostly seen in uterine papillary serous cancer, in between about 25 to 45% of cancers, which is really a hard group of patients to treat. As you know, they tend to be refractory to chemo. And we saw response in this tumor. So we've done this before, and we used trastuzumab, and we know that it really had limited single agent activity. It was kind of always the response rate of 0%. But now we use it in combination. So Dr. Fader talked about this in March of 2020. It was also reviewed at this SGO. Trastuzumab in combination with carboplatin and paclitaxel improve prolonged survival in HER2 amplified uterine papillary serous cancer. So these are patients that have stage 3 or 4 advanced endometrial cancer, or their disease is recurrent. They have testing. Again, this is very important for your doctor to be testing you for HER2 and all these markers your doctor has to specifically order and test for. It's not like most times it's not a reflex thing done by the pathologist. Some centers it is, but, and they were either randomized to just carboplatin and paclitaxel, which is the most active agents in this scenario, or they were given paclitaxel and carboplatin with trastuzumab for 21 days. And in fact, we saw here, remember, we want to be on this upper line, that patients on primary treatment that were newly diagnosed, they had the best outcome. Recurrent disease, a little less, but they still had a better outcome, like 7 months as compared to, 13 months here. So really for patients that are treated for primary disease, they really had the most effective response. And that was a durable response. You see here, almost 2 years. So we know that this drug works, these combinations work, and so now we're building on these hormonal therapies, and we're using hormones which have very little side effects for the most part, especially trastuzumab has very little side effects, very different actually from chemotherapy. Chemotherapy, with carboplatin and paclitaxel, you can lose your hair and have neuropathy, but trastuzumab doesn't have those kinds of side effects. So the side effect profile is tolerable in these patients. And there's another drug. This is new. This is from Joyce Liu, who's at Boston, using adavosertib, which inhibits WEE1 and may be very active in p53 mutant background tumors. So these are also tend to be serous tumors because they tend to be p53 mutant, which means that their tumor suppressor gene p53 isn't working. So what happens is they already have an abnormality in the growth phase of the cell and they can't repair it. So what happens is that causes a lot of stress on other areas where your body, where other checkpoints where you can actually interfere and repair cells. But if you use this WEE1 inhibitor, your cell loses all of its backup to repair these cells. So these tumor cells can't repair themselves, so they die. And that's really what you want to do, kill these cells. So, and that's called synthetic lethality in p53 mutated patients. So they took recurrent or persistent uterine cancer patients and gave them this WEE1 inhibitor, and they found a 30% overall response rate that lasted about 6 months. 9 months. And they were about disease-free for about 6 months. But unfortunately, this was a pretty toxic drug. 55% of patients needed a dose reduction. So again, these are toxic agents. They may not cause alopecia. You may not have neuropathy, but it doesn't mean, or if they're oral, it doesn't mean that they're not toxic. It's just a balance of toxicities, and you really need to work closely with your physician and your team. Metformin was used, many of you may even be on metformin. It's a drug that's used for prediabetes, for insulin resistance, which is very common in endometrial cancer patients, especially those with endometrioid types or obesity related. And it also somehow inhibits this mTOR pathway that can be active in endometrial cancer. So what they did was, this is a Gynecologic Oncology Group's trial, which looked at carboplatin and paclitaxel and metformin, which is taken twice a day, or just carboplatin and paclitaxel plus placebo. And it was a phase 2-3 study with stage 3 or 4, like advanced disease or recurrent disease. But unfortunately, they didn't see it work at all in this study. BMI didn't make a difference. So actually the study was stopped, but it did show something interesting, that racial disparities showed that African-American women did worse and had more uterine serous carcinoma, which is, as we know, tends to be chemo resistant. And have a much lower response rate to therapy in general, but actually African Americans had an even further lower response rate to therapy. So it's supposed, out of 91 African American women, they had a 43% response rate rather than a 64% response rate. They had a worse overall survival and progression-free survival. So this on one hand, it showed that metformin didn't work with chemo. Metformin's still being studied in other trials with hormonal therapy, IUDs and other hormonal therapy, but it should be known that it's still a great drug for if you have glucose intolerance and if you've been prescribed on it by your primary doctor for other reasons. But in this study, it didn't work. It is still being studied in other combinations. And the other thing that really was, I think it was a big part of SGO this year, looking at just, disparities in outcomes in endometrial cancer. As we said, endometrial cancer incidence is rising and their survival is going down. And so that's very concerning. So they looked at, this was a very interesting paper, abstract actually, by Dr. Jones, which said, showed that Black women had a 9-fold lower enrollment in clinical trials in like the Deep South. And there were multiple barriers that exist that causes this. So what they did was they developed a program to increase enrollment in clinical trials. And all new endometrial cancer patients that were assigned to a lay navigator, someone that could speak in layman's terms. And then they also had them have a clinical trial education module for all patients that was mandatory. And they found that 23 out of 277 Black women enrolled in these clinical trials, which is about 8.3%, which is a 1.15 fold higher enrollment that was expected in this population. And also what was really interesting is they said that if women were enrolled in these trials, they actually had a better PFS or progression-free survival, which we know in general, patients on clinical trials do have better outcomes. So this was actually interesting. The conclusion was that clinical trial disparities in enrollment can be overcome with specific interventions aimed at improving care of these women. So, and even if you think about this, we can think about maybe this is similar in the Hispanic population if we were to do the same type of a study, or other, minority groups, that really we need to sort of really put resources into helping these patients understand what clinical trials are. I think there's a lot of fear around clinical trials in general, in all of the population, and actually really speaking to patients within their ethnic group actually may be helpful, as outlined in this study. So really the landscape of therapy in endometrial cancer is changing. I'd like to quote a medical oncologist, Dr. Matsoulianis. She said recently in the ASCO post that this is the start of a new era in endometrial cancer clinical trial drug development and improved patient outcomes. And I have to say, for me, this was a really exciting SGO. The molecular characterization of endometrial cancers is very important. You need to have next generation sequencing. You need to have hormonal status, ERPR, HER2/neu, POL, MSI, MMR, tumor mutational burden, TMB. These things are very important. And based on those, you can be categorized where your optimal treatment will be. Remember, primary therapy for early stage disease pretty much is surgery and radiation. But if you have recurrent or advanced disease, there's a lot of other options. So really, endometrial cancer is not a one-size-fits-all situation anymore, and chemotherapy is not our only option, but it still is an active in this disease. But we have a lot more options that we've had. And I would just like to thank you, and I would like to thank all the patients that have had endometrial cancer. You're courageous, and you're amazing women that inspire me every day, and I'd like to personally thank you. So here I work at Lenox Hill Gynecologic Oncology. Here's our email. We're happy to help in any way we can, and it's really been a pleasure and having the opportunity to be here today. Thank you.
Thank you so much, Dr. Villella. That was really interesting, and it's wonderful that so much is going on. It seemed like it really was an exciting year.
Yes.
At SGO. So we're going to start with the Q&A. You can still submit questions in the Q&A section at the bottom of your screen, and we'll try to get through all the questions that were submitted, but we may not be able to due to time constraints. So I'm going to start with a number of questions about serous uterine cancer. What is the latest treatment for serous high-grade uterine cancer?
So if you're newly diagnosed with serous high-grade cancer, I have to say this is an area where there's, a lot of work being done and a lot of new options. So one thing is obviously surgery is, if you're early stage surgery, hysterectomy, staging procedure, lymph nodes, you can have sentinel lymph nodes with plus or minus a lymphadenectomy. That's depends on a lot of things, and also omentectomy, searching of the whole abdomen, sort of like a staging procedure. And then based on those results, whether or not you need chemotherapy and or radiation, usually it's carboplatin and paclitaxel and radiation. Now, if you're HER2 positive, you would get trastuzumab. And also you would need to be tested for MMR, mismatch repair, microsatellite instability, and the pole mutation. So I think there's lots of options now, and those are in general why you need to have all those tests, because we have to know what's best for you. Not everybody's tumor is the same, and that's what we're really realizing. If anything's a takeaway, it's that we are no longer, one size fits all. So in all of our cancers, but actually now in endometrial cancer, so that's good.
And is the treatment the same for all stages of serous uterine cancer, including stage 4, or it's going to vary depending on
it's going to vary. So right now for stage 1, say for stage 1 or stage 2, you'd probably get paclitaxel, carboplatin, somewhere between 3 and 6 cycles. That's also debatable. There's a lot of debate in endometrial cancer also. And then depending on uterine factors, what type of radiation, tailored radiation. But if you're HER2 positive and you're advanced, stage 3 or stage 4, you'll likely get the trastuzumab if you're HER2 positive.
Oh, okay. And the last question about serous uterine cancer was, is it always grade 3?
In general, yes. Mm-hmm. Yes. It's just the way the tumor. That's actually a very good question. In ovary cancer, you can have a grade 1 serous tumor of the ovary, like we call it low-grade serous, and acts very differently than the high-grade serous. And the real hallmark of the P53 signature in these high-grade UPSCs is the P53 signature. That makes it very different than grade 1. So usually in uterine cancer, it's usually grade 3, yes. But in ovary, it could be grade 1.
Oh, okay. Thank you. Very interesting. What are the best practices for surveillance for post-uterine cancer treatment?
Good questions. So we still do physical exams. So we see our patients, for the first year, every 3 months, every 4 months for the second year, every 6 months for the next 3 years for most patients with endometrioid. Patients who are more advanced disease, we tend to see them a little closer, 3 to 4 months for a little bit longer. The highest time to recur is within 3 years. And so usually, depending on your stage and your recurrence risk, you do a pelvic exam, a physical exam complete. And then really, there's no real guidelines on imaging. I actually don't do a lot of imaging on my patients, maximum once a year for advanced tumors. And really, after 3 years, if the scans are normal, I sometimes don't repeat them. There's really no no sort of flow chart what to do there. We don't do pap smears anymore. That's been shown to not, increase any detection. The one thing we do is you have to make sure if you have bleeding, you have to go to the doctor. Most times it's nothing. If you've had radiation, many times it's due from radiation, toxicities and side effects. But that's one of the side effects of recurrence, because the most common place to recur for most endometrial cancers still is the vagina.
Oh, okay. That's very interesting. Thank you.
Yeah. And for serous tumors or clear cell tumors, we tend to also check CA-125s and blood tests.
Oh, okay. That's good to know.
Yeah.
This is one from the audience today. Is it possible that one of the reasons Black women present at later stages is because their symptoms, i.e. vaginal bleeding, actually show up later in the cancer progression?
No, actually, that's such a good question. And in fact, there was a study done on this a few years back. And what was interesting is that many Black women have like 40% of them have like fibroids, and they are used to heavy bleeding.
Oh.
And so initially when they have the bleeding, they may not go directly to the doctor because they're so used to, having bleeding. It's not so, they've been accustomed to that in the past. And so they don't maybe go to the doctor right away. So that's one of those things. It's not so much that the bleeding is later, it's that maybe they get the attention later. But really it's multifactorial actually.
Okay, thank you. If someone does not do well with the Lenvima and Keytruda combination and our MSS, what are the other options?
Well, it really is going to depend. When you say you didn't do well, I mean, I would want to know, what didn't you do well on? Did you have bad hypertension? Did you feel horrible? Did you have diarrhea? So we need to tease out what the diagnosis was. Maybe, the dose they originally started out with the Lenvima was 20 milligrams, which is really high. So the thought is maybe you should start lower. Maybe you just need to go back to like 12 milligrams and maybe start low and go up. So that's one option. The second option would be, do you need antihypertensives? I mean, if it's just hypertension, you could, maybe you just need medication. If it's from the pembrolizumab, there's no dose reduction. So if you have, immune-related, diarrhea or thyroid issues, hepatitis, there's a slew of endocrine problems that you can have. Maybe in those situations, you could drop the pembro. And then if you have to do that, at that point, the single agent lenvatinib, is probably not going to work. So I think it would really depend what the toxicities are, and you really need to tease through that with your doctor.
Sure, that makes sense. What is the percentage or probability of cancer returning or metastasizing to another location after 5 years of being cancer-free?
Okay. So, recurrences happen most likely within the first 3 years. This is a very general statement, okay? At 5 years, the cancer recurrences drop off dramatically. So it's kind of going up, up, up. It kind of goes down, and then it takes a sharp turn. So it's much lower, okay? It depends on your stage. It depends on your treatment. It depends on what you've had, but and your risk factors, But in general, those risks should go down. So that's why we normally stop seeing surveillance patients at 5 years, and we send you back to general GYN for like general surveillance, because it's really less, than 10% that your chances, your cancer can come back. It goes down and down over time, but it doesn't really go to zero for, for all cancers. So for instance, breast cancer, those patients need to be followed for at least 10 years. Because their recurrence risks don't go down to zero that fast. So, I would say that it's very low risk. If you've made it to 5 years, congratulations, and I wish you the best. I wouldn't forget about, the fact that you need to go to the doctor and have a checkup, but your chance of cancer coming back goes down dramatically, over 5 years.
Okay, thank you. Does the research that you've been talking about today apply to uterine sarcoma also?
So some of the trials now, did have a subset of groups with carcinosarcoma. And those of you who don't know, carcinosarcoma is a very aggressive type of cancer. Even at stage 1, it has a very high recurrence risk, somewhere between, 20 to 30%. And it tends to be resistant to chemo and treatment. So it's very concerning, but there are some studies that have shown that actually a subset of patients with carcinosarcoma can respond to some of these therapies. And usually the problem is a lot of the carcinosarcomas, they don't actually have any mutations. So they don't qualify for a lot of these agents.
Oh, okay, thank you. Is early clear cell uterine cancer treatable?
Yes. So clear cell carcinoma, which we didn't talk about today, it's sort of like a very aggressive tumor that histology, clear cell is the histology. So the uterine is the organ, that's the site, and the clear cell is the actually histology, which is like the type of its cell that kind of can predict what kind of mutations it has, if it's going to respond to treatment. And it tends to be very chemo refractory. It doesn't really respond. Clear cell carcinomas that are metastatic are very hard to cure, but clear cell cancers that are confined to the uterus, they can be treated, but the problem is that when they recur distantly, like serous tumors. They can recur in the lungs, in the abdomen, by the diaphragm, and so systemic chemotherapy is often indicated, although the tumors are not very chemo responsive. So it's a very troublesome cancer to treat.
What's the percentage of cases of clear cell? Is it pretty infrequent?
Yes, it's very small. It's less than 10%.
Oh, okay. And speaking of something, I think which is fairly infrequent is what about Müllerian tumors?
So mixed Müllerian mesenchymal tumors, or triple MT, or now we call them carcinosarcoma. Those are the same tumors that we were just talking about. Again, those tend to spread hematogenously, so they spread through the blood. So they can spread, advance. They can go to the liver, very commonly lung, and they're very aggressive tumors as well.
Oh, okay. This is a good question for our times now. If a patient is on immunotherapy and is diagnosed with COVID, will they be likely to have a more severe case?
Well, I think it depends on what your symptoms are. If you are asymptomatic positive for COVID, I don't think so. But if you're sick with COVID, that's concerning. But actually, I just read something today that for endometrial cancer, COVID, obviously, we had a lot of delays with endometrial cancer, and really the outcome wasn't changed unless, in general, that the treatment wasn't, the surgery, for instance, wasn't delayed past 45 days. If it was past 45 days, then it was, quite concerning. And actually, that's what happened back in, March and April of 2020. So I think it depends how symptomatic you are from your COVID. I would say that COVID is real. It's a problem. It's hopefully things are getting better now. If you can get your vaccine, I would get that as soon as possible. And also don't forget that you still, cancer doesn't care that there's a pandemic. So,
right. Absolutely. Yeah. Does tumor size influence the type of treatment?
Yes. So we really didn't talk about, the stage 1 tumors and risk factors for adjuvant therapy that put you into high intermediate risk, because, I only had an hour here, but I will tell you that, it does. And those are one of the risk factors that can put you into what we call high intermediate risk. And that's part of the Mayo Clinic criteria. Greater than 2 centimeters is a risk factor for recurrence. And so that might increase your recommendation to get radiation after treatment, after surgery, I'm sorry.
Oh, okay. What is the current thinking about radiation for uterine cancer, uterine stage 3C, with no evidence of disease after chemo?
So, this is if you brought 10 GYN oncologists in here, we would all have a different opinion. This is very, endometrial cancer has always been very difficult to develop sort of care maps. And if you look at NCCN guidelines, which most of us use, there's lots of options. And the reason is because we don't really know what's, how much is too much. Should you give 6 cycles of chemo or 3 cycles of chemo? Should you give 3 chemo and then the radiation and then finish the chemo, or that sandwich technique? There's a lot of things, there's a lot of factors. So I would have to say it depends on your uterine factors. So if you're 3C, you have nodal involvement. So usually those patients would get chemo. Now, if you just have pelvic nodes, what does your uterus look like? Does it look like, was a tumor invading through the wall of the uterus? Did you have lymphovascular space invasion, which you probably did if you have a positive node? Do you have a tumor that's huge? Do you have a tumor that was invading the cervix, lower uterine segment? Was it going through the wall? All of these things really depend what kind of radiation you have. Right now, we're trying to, if we do the chemo, we're trying to, minimize the radiation if we can. So for instance, if you didn't have a very huge tumor, it wasn't going through the wall, and it wasn't in the lower segment and you got chemo, maybe we just give you vaginal radiation. But usually endometrial cancer patients that are stage 3, most of them are going to be getting radiation, but it's still, I'm sure you can get a lot of different answers. And I think it really depends on the uterine factors. So that's a long answer.
No, thank you. Have you treated any patients with a frame shift mutation in the P53 gene? If so, does their disease progression differ from patients with point mutations?
You know, these are nuances that I have not seen. You know who there are a lot of really experts in this field, Dr. Joyce Liu, and in Boston, she's somebody who I would, she probably had more experience. I wouldn't be able to say between those two different mutations.
Okay,
with enough experience. So I'm going to plead, I'm going to pass the question.
It sounded like a complex, very well, fine-tuned question there. So, and this is going to be the last question, actually. Could you talk a little bit more about HER2 when you talked about if you're HER2 positive and have uterine cancer? Is that treatment that you were discussing, is that related to Herceptin, or is that
so trastuzumab is Herceptin, and now there's another agent called pertuzumab, and some of them are used in combination now because they act synergistically in the HER2 blockade. So this is really new. This is actually very new, and these studies are ongoing. But that's another option for treatment that patients that are HER2 positive. Yes.
Oh, okay. Yeah, because we've heard so much about HER2 with breast cancer, so it's interesting to learn more.
Yeah, same drugs, different disease. But you see, the difference now is, that's actually interesting that you said that, Kitty, because now we can maybe consider, instead of treating all uterine cancers the same and all breast cancer the same, maybe we're going to start treating them based on the mutations.
Oh.
So actually, and there's a lot of trials that are doing that. They're looking at that. They're called basket trials sometimes. And they're looking at, if you have, this mutation, you get treated with this, whether you have breast cancer and you have HER2, or you have uterine cancer and you have HER2. And this is a different way of thinking, because we're kind of like, it's hard for us to compute this and digest this because we weren't doing that. But actually, I think that's really what's going to be happening. We're going to treat patients based on molecular characteristics rather than the organ that it started at. And
that's incredible.
Yeah, and that's why this one size fits all, it's not anymore at all. And it's not even one organ fits all anymore. It's totally different. And right now, not everybody has the opportunity to get all this next generation sequencing. It's expensive. Not everybody has it. Insurance doesn't always cover it. There's lots of places that don't do it in-house. So this is going to be an area that we'll see, where it takes us. But it's very exciting.
That's incredibly interesting and exciting. Thank you. So I think that is our last question. Thank you so much. This was Dr. Villella. This was such an informative program. And thank you to all of you who are on the webinar for participating and submitting great questions.
Yes, very good.
Really excellent questions. Please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also be in a follow-up email. So thanks again, Dr. Villella and everybody, and have a great evening all.
Yes, thank you.
Bye-bye.
Bye-bye.